So you might see a patient come back after a knee meniscus arthroscope and they're in a lot of pain. You do a nerve block here, many of them will get better. So when we're doing neuromodulation targets, typically you'll target the saphenous nerve or the femoral nerve in the adductor canal. That's a nice way to get access to a majority of the fibers that go to the knee. Or the sciatic nerve, which you can get gluteal, subgluteal. I usually go subgluteal or in the back of the hamstrings before it bifurcates. If it's the knee, you don't need to go up so high. And it bifurcates into the tibial nerve and the common peroneal nerve. And the sciatic nerve could be the most difficult thing to find, and it could also be the easiest thing to find. It really depends on the patient and the scanner. And it sometimes appears circular or oval or triangular. It has a lot of different shapes. And one thing I've learned about this nerve from one of my attendings when I was a fellow is it's very resilient. Meaning he was a big muscle pain guy, and he would do a lot of trigger points. And he went at the piriformis in that region very aggressive with a spinal needle, and he must have stabbed the nerve like 10 times on this patient. And no permanent deficits. This is not the spinal cord. I'm not advising you to stab the sciatic nerve, of course, but it's a very resilient nerve. Who here does IPACK? In the pain office or in the OR? OR. OR? Okay, so I'm a regional anesthesiologist. I brought this procedure to my pain office, and the results have been fantastic. What is this? This is a block for posterior knee pain. So these patients have pain in the back of their knee. They go to orthopedics or their pain doctor, and they just get a regular knee shot or a genicular block, and it still doesn't help. Maybe they have a Baker's cyst, maybe they don't, but the back of the knee hurts. So many people don't do this, and it's a very simple thing to do. And unfortunately, there's really, as far as I know, no particular CPT code for this block, so it might be a little challenging, but what it really is an articular branch of the knee or a genicular block posteriorly. So maybe you could call it the tibial nerve, articular branch of the knee. There's different ways to do it. But basically, you take the needle, you go from behind the knee, deep to the popliteal artery and at the posterior capsule of the knee. There's a tibial nerve. You should be nowhere near it. And here's a short video of me doing the injection with a little bit of steroid and local anesthetic. Tibial nerve again, posterior capsule of the knee. And that's my needle. It doesn't take much, maybe 20 milligrams of depomedrol and 3 mLs of 0.25% bupivacaine. They don't even get a numb foot. This is not a sciatic nerve block, so they could just walk out of the office fine. And I just did my first PRP shot with this as well a few weeks ago, and the patient's doing quite well. So it's something to really look at. If you're not doing it, you're going to help a lot of people. Okay, TMJ and headaches and occipital pain. Well, I don't do my occipital nerves like this, actually. This is just an image of the occipital artery, and you don't even see the nerve too well, but it's right next to it, right? This is, many of us grew up doing the blind approach to the occipital nerves. You just feel the pulse. I do the ultrasound approach now at C2. I find the nerve above the orbicularis muscle, and it's quite useful. This is a TMJ shot. I don't really do much of this either, so I'm not the TMJ guy, but I've done it.